Hello, everyone. Welcome tonight to Doctors in Politics Tuesday Talk, where we have today a very uh, credentialed and amazing physician, Dr. Paul Song, whose expertise on healthcare policy has really been sought out by many campaigns and also the California Department of Insurance. He's currently the California chapter president for Physicians for a National Health Program. He's also the CMO for NKMax America, and he's a practicing physician at Dignity California Hospital. And we're very excited for him to particularly talk about the United States healthcare system that's really been brought to the failure because of the COVID-19 pandemic. But we all know it was on the brink of failure, and COVID just really made it a lot more worse. But once again, we'll have Dr. Song take it away.
Well, again, thank you so much for having me part of this, and I appreciate everyone tuning in. What I'm hoping to do today is just give everyone an honest overview of our healthcare system and also kind of show you sort of the areas that are deficient that have really been exposed and magnified by the COVID crisis. So the first slide that I would like to start with is just what the Affordable Care Act means to many of us. So while it's done some good things, such as protecting against pre-existing conditions, expanding Medicaid, helping with Part D coverage gaps, it's also done some things such as increasing taxes for some, also increasing cost sharing along the way. But as we think of the Affordable Care Act, I want to point out some things that it did right, as well as things that still are not fully addressed. So in the run-up to the Affordable Care Act, there were 3,300 registered healthcare lobbyists for the 535 members of Congress, and more money was spent lobbying Congress than was spent on the Bush-Kerry election. And it was so bad that The Lancet, which is a very reputable medical journal that many of you know, took the unusual step of dedicating a full issue to the healthcare reform process in the United States. And they concluded that the healthcare reform process in the United States exposes how corporate influence renders the US government incapable of making policy on the basis of evidence in the public interest. And what do they mean by that? $1.2 million was spent each day. In total, more was spent lobbying Congress than was spent on the Bush-Kerry election. And that's why there was no public option, no insurance rate regulation, and no drug price regulation. And when you think about your patients or in your practices, what are the areas that most of your patients complain about? It is runaway drug costs and runaway insurance premiums. So as much as the Affordable Care Act did have some good intentions, it was sort of doomed in terms of addressing some of the issues that really affect people day to day. So here's where we are right now. You've heard many people say that we spend twice as much on healthcare as any industrialized nation. You can see on the upper right-hand corner in terms of the per capita spending in 2018 of us compared to all of the other industrialized nations that are even in that range. And then on the left, you'll see that not only are we spending a greater percentage of our whole gross domestic product on healthcare, but we also have a lower life expectancy. And down below in the lower right-hand corner, you'll see that in spite of the fact that we spend twice as much per capita, that we still have a larger percentage of our patients who will have trouble with medical bills each year. Not only has it been tough for people who get sick, but when we look at our overall healthcare system, which is really developed on an employer-sponsored healthcare, meaning the majority of you on this call, the majority of your patients seem to get their healthcare coverage through their employers. What's happened is over the last 10 years, wages have remained relatively flat. Inflation has remained relatively flat, but more and more people are being asked to contribute each month of their paycheck towards their premiums. And then when they get sick, they're being asked to pay more in terms of deductibles and copays. So it's no wonder that people have less take-home pay. And at the same time, many people are stuck in jobs that they hate solely because of the healthcare benefits that they afford them. The other thing is, if you look at the number of people that have been asked how difficult it is it for you each month to pay your monthly premiums, this has gone up to 37%. The number of people that report difficulty paying for copays has gone up and the number of people that have reported difficulty paying for their deductibles has also gone up. And here's the part that I think is very important for people to realize. When you hear politicians saying, I want to give everyone coverage, coverage really doesn't mean anything if the co-pays and deductibles are so expensive that it causes people to delay seeking treatment. So up above, you will see that in 2019, 1 out of 3 people that had insurance said that they put off seeking treatment because of cost. And then 1 out of 4 people put off treatment for a serious condition. So what good is it to have a piece of paper that says you have coverage if your copays and deductibles are so expensive that it discourages you from seeking care? And that's the first thing I think we need to realize, that giving coverage is meaningless for a lot of people. And then if you look down below, when you break it down into communities of color, our national indigenous folks, our African American population, our Hispanic population, they tend to have more people in their communities that, again, delay seeking care because of cost. The other part is because we didn't have any regulation to address prescription drug prices, we've had up to 45 million Americans in a single year report that they didn't fill a prescription. And 1 out of every 5 seniors also reports that they don't fill a prescription because of the cost of prescription drugs. And let's not forget that Medicare still is unable to, is prohibited from negotiating drug prices. And then the other thing that you may hear about is this thing called narrow networks. And what that means is that when you are in an insurance plan, they only allow you to see 25% or less of the physicians in your given area. So for some of you who have a plan, and let's say you're in a car accident and you get sent to a hospital that's, quote, not in your network, you get surgery from an orthopedic surgeon that's not in your network, an anesthesiologist that's not in your network, all of a sudden you're going to be asked to pay a lot more out of your own pockets. But even if you wanted to go see doctors, chances are most of you are in insurance plans that don't allow for you to actually see doctors, so that you want to see, or go to the hospitals that you want to see. So when you hear people say, well, they don't want the government getting between you and your doctor, many times it's the insurance industry that's already doing that and limiting our choice of who we can see and who we cannot see. So we have this very complicated healthcare system. Some of you on this call may get your coverage through your hospital that you work for. Maybe 1 year it's United Healthcare, and then the next year your hospital decides to have a health plan through Aetna. And then some of you may lose your jobs and have to get Medicaid. Well, the problem is when you go back to see your doctor each year for your annual checkup, they now have to determine, am I in your network? What's your copay? What's your deductible? Or they may say, you know what, your insurance doesn't have a contract with us. You can no longer see me. And all of this administrative waste of trying to figure out whether or not they can see you or what your copays, deductibles are, applies not just to you when you open your own practices, but also for hospitals that have to spend a lot of time figuring this out. And as a result, it's a very convoluted mess. And then next year, let's say you turn 65 and you have Medicare, and you've got to figure out what is going on. So this is really that administrative inefficiency of having a multi-fragmented, multi-payer system. And just to show you that from 1970 to 2015, the relative number of doctors that were trained was relatively flat. Whereas if you look at the number of administrators with healthcare plans and such, and hospital administrators and such, it's really ballooned. And if you look at the curve down below in terms of what's happened to U.S. healthcare expenditures, the curves almost mirror itself. I wonder if it's coincidental that the reason costs are so high is because we've had this explosion of administrators, many of them who are simply hired to deny care and to try to reduce costs for the insurance industry, but at the same time, they're driving up the overall cost of healthcare in the United States. And as far as administrative costs, you can see that the United States spends a greater percentage of their total healthcare on administrative costs compared to all of these other industrialized nations. And especially for hospitals, they spend roughly 25% of their entire budget on administrative costs. And right now, in 2018, Duke University reported that they had more billing clerks than they did hospital beds. So you can see all of this money that's actually being taken away from actual patient care or improving quality of care that's really designed to just handle all of the billing and the complexity that's associated with our healthcare system. And it's gotten to a point where we actually spend more on administrative costs as a nation per capita than we do on long-term care. And when you look at the aging population, people who are developing chronic illnesses, we actually should be spending more money taking care of for long-term care than we are on administrative costs. And it's no wonder that we have been named as the least efficient healthcare system among industrialized nations by the Commonwealth Fund. And in the Bloomberg World Rankings, we're not even listed as an efficient healthcare system. And so let's talk about how COVID has really exposed some of the other deficiencies in our healthcare system. As we now are exceeded 350,000 deaths and continue to climb, let's look at some of the problems that this has really exposed. So during the Democratic primary, you had President-elect Biden criticize Senator Sanders' plan, and he used Italy as an example back in March, saying that a single payer or a universal healthcare system showed that as they had more deaths at that time than the United States, that it was not an efficient healthcare system. But now look what's happened since then. All of the countries that have a universal healthcare, particularly those with a single payer system, have done a remarkable job at controlling deaths, whereas our system is really out of control and continuing to climb. The other thing is you had Senator Klobuchar say that a Medicare for All plan would kick millions off their employer-sponsored healthcare, but let's look what the pandemic has done. This is as of October, and we know the numbers have gone up more since then. But if you look, the number of people that lost their employer-sponsored healthcare as of October was 7.7 million, and then an additional 6.9 million dependents lost their healthcare because their spouses or their primary providers lost their healthcare. So at a conservative estimate, over 14 million people in the United States have lost their healthcare during this pandemic, employer-sponsored healthcare. And if you look at the occupations with the largest number of uninsured workers, it was really our frontline workers. It was our cooks, our cashiers, waiters and waitresses, the people that clean our hospitals and clean homes. And as a result, these people that didn't have insurance when they were exposed to coronavirus and started to show symptoms, many of them delayed seeking care because they just didn't have coverage. And as a result, they were able to potentially spread this disease far more, particularly those that lived in multi-generational families. And if we look at all the people that lost their coverage during COVID in the United States, look at all of the people that lost their coverage due to COVID in all of these other countries. So again, another myth was exposed as a lie that our employer-sponsored healthcare was really secure. So one of the things that at least I would argue is healthcare should be a human right and not a job perk. And the other thing you heard on the Republican side is that if we went to a government-run healthcare plan, we would eventually start to ration care. Well, unfortunately, this is from just a few days ago. Here in California, we are indeed rationing care because we've run out of ICU beds, run out of oxygen, and are short-staffed. So all of the ideas of an employer-sponsored healthcare plan working best, the U.S. current healthcare system doing the best, has simply not borne out. And here we have rationing of care in a for-profit, mostly private healthcare system. But here's who has done well during the pandemic. You see that United Health Group has had record profits during their second quarter, and Anthem is doing quite well as well. So it's no wonder that right now during the pandemic, if you poll people who've lost their health care and such, about whether or not we should now do an emergency where everyone who has lost their coverage should just be enrolled in Medicare. 76% of all voters support this, including 88% of Democrats, 63% of independents, and even a majority of Republicans. But Before we actually talk a little bit more about Medicare for All, I wanted to at least say that we still have an imminent threat, despite the fact that Donald Trump has less than 8 days in office. Remember, there is the decision looming among the Supreme Court. And here are all the things that over the last 4 years that Donald Trump has and his administration have done to really undermine our healthcare system, from removing the individual mandate to imposing work requirements on Medicaid to reducing the reimbursement to insurers for low-income deductibles. And as a result, even before the Affordable Care Act, we saw the number of uninsured spiking up here in the United States to the highest it's been in a long time. We had 33.2 million people uninsured prior to the pandemic. And let's not forget that if the Supreme Court does rule in favor of repealing the Affordable Care Act, roughly 135 million Americans could be denied coverage because they have a pre-existing condition. The ban on lifetime coverage caps would be eliminated. As a radiation oncologist who treats a lot of patients who've been fighting cancer for a long time, I can tell you that many of these people pre-ACA had reached their lifetime caps within the first 2 years of their illness. And this would be devastating to have these reinstituted. And then a lot of the essential benefits would also be eliminated as well. A repeal of the Affordable Care Act would really have a disproportionate effect on our communities of color as well. So this is really obviously the first major challenge. Hopefully the Supreme Court does not rule to overturn it. But here are the problems with or without the repeal that we have. Now it's estimated about 40 million people that are uninsured. We don't have coverage for our undocumented brothers and sisters. There's no insurance rate regulation. There's no drug pricing controls. We still have very narrow networks. We still have very high copays and deductibles. We have tremendous administrative waste and an overall inefficient system. And also, we just don't have a lack of health security with job loss. One of the things that's happened is the public option seems to be gaining support more than Medicare for All, including among Republicans. And President-elect Biden has indeed pushed for a Medicare for All plan. It would be potentially to expand Medicare to the age of 60, expand Obamacare tax credits. Right now, credits are only available for people at 400% or less of the poverty level, but he's trying to expand that. He's allowing uninsured in red states where the governors are refusing to expand Medicaid to potentially be automatically enrolled in a public option. So these are the essential tenets of what President-elect Biden is trying to do. And, again, they would maintain Medicare, Medicaid as it is. They would maintain the employer and marketplace insurance. They would basically try to reduce the cost sharing by increasing subsidies across the board. So there are a lot of positive things about the public option. But let's talk about Medicare. This is Lyndon Johnson signing Medicare into law. I was born actually 2 weeks before Medicare was signed into law. And Medicare, despite the fact that it takes care of an older, sicker population, most of the patients have chronic conditions. They tend to be older. Many of them are in fair or poor health. Despite the fact of taking care of sort of a higher risk pool, Medicare has done a tremendous job of controlling costs relative to the private insurance industry. So this is despite the fact that Medicare is prohibited from negotiating drugs or bulk medical supplies, and yet patients who are enrolled in Medicare have greater patient satisfaction than they did when they were with private insurance. So I would argue, instead of having this convoluted system of multi-payers, of varying degrees of copays and deductibles and narrow networks, that a single payer system would be a much easier system to administer and one that would be much more efficient. Now, when Senator Sanders initially introduced his Medicare for All plan, a lot of people, not just Fox News, but a lot of corporate Democrats really criticized it as costing $32 trillion. And ironically, on Fox and Friends website, they asked the Fox and Friends viewers, would they support this despite the cost? And 3/4 of the people overwhelmingly said yes. But let's talk about this study because I think it's very dishonest in how it's been used. First of all, the Mercatus Institute is a very conservative think tank funded by the Koch brothers. But they found that Bernie's Medicare for All plan would cost $23 trillion. But what the pundits on both sides of the aisle failed to mention is they also in the same study said that it would be cheaper than if we stayed with the status quo while insuring everyone. And that's something you never hear, you never heard during the Democratic debates, and you never hear during the Fox News criticism, is that even if we don't do a Medicare for All plan, we are going to spend $2 trillion more over the next 10 years while still having nearly 35 to 40 million people uninsured. And let's not forget, this is the Partnership for America's Healthcare Future. They found that a public option could add $700 billion to the federal deficit in the next 10 years. So again, unlike Medicare for All that would save $2 trillion over the next 10 years, a public option will only add more cost to our overall healthcare system. So let's just explain what the difference is between Medicare and a public option. Medicare would cover everyone, Medicare for All would cover everyone, whereas a public option would continue to exclude our undocumented brothers and sisters. Medicare for All would not be tied to employment, whereas a public option does not eliminate employer-sponsored coverage. Medicare for All would eliminate copays and deductibles, would allow you to choose your doctors and hospitals, whereas a public option maintains narrow networks. A public option would add additional cost to our federal budget, whereas Medicare for All would save trillions of dollars by eliminating administrative waste, which is still kept in a public option. And Medicare for All would allow us to negotiate deep discounts in drugs and cost of services, where a public option really just maintains the current system as is. Now, about 4 years ago, I spoke at a Bernie Sanders rally, and I used a term to refer to members of Congress that were beholden to the pharmaceutical industry and private insurance industry. And I used an insensitive term, got in a lot of trouble. And for any of you on this call, if I offended you, I apologize. Certainly, I should have used a better term. But let me show you what I meant by that. Just in the last year, it's been found that there were 130 Democrats who refused to back a Medicare for All, and it found that they received $43 million in donations from the pharmaceutical industry and private insurance industry. And recently, during the Democratic convention, it was discovered that the Partnership for America's Healthcare Future that announced that $700 billion cost of the public option is a group that was created by the health insurance industry, pharmaceutical and hospital lobbying groups to oppose Medicare for All. Well, they've now focused their attention on fighting against the public option. And right now, this organization is led by former Clinton staffers and top Democratic congressional aides. And their whole idea is to basically make sure that the public option fails. And indeed, it said within 24 hours of the launch of industry news ads, anonymous Democratic congressional sources were telling The Hill that Democrats likely would not bother with a public option fight next year if Biden wins the election. So everything I was saying about my use of choice of words may not be correct, but this was everything that I was talking about, that we have elected officials and former elected officials and their aides that are doing the bidding of the pharmaceutical industry and the private insurance industry rather than doing what's right for our constituents. So I'll just conclude by saying this. My mom came to the United States in 1951. She was a refugee during the Korean War. She ended up graduating from Columbia Teachers College. And the first person to hire her was the late, great Shirley Chisholm. Ms. Chisholm, for some of you who may not know, was the first African-American woman elected to Congress. She ran under the mantra of being unbought and unbossed. And in 1972, she ran for president. And she said, "We have never seen healthcare as a right. It has been conceived as a privilege available only to those who can afford it. This is the real reason the American healthcare system is in such a scandalous state." And I would really submit to you that here we are some 48 years later, and I think our healthcare system is even in a more scandalous state today than it was in 1972. So what I would ask each of you to do is really learn as much as you can about our healthcare system. Really come to your own decisions on what you think is the best policy. Kind of as you are diagnosing and working up a patient, you're doing your differential diagnosis, you're looking at the literature, you're looking at peer-reviewed studies, and then trying to figure out what's the best practices for your own patient. And I would ask you to apply that in terms of how you see what is the best system for our healthcare system. I don't want you to take my word for it. I don't want you to bring in somebody else's ideology. I really would hope that you would take the time to learn about it. And once you do think that you know what the right system is, that I hope you will get active, not stay on the sidelines, and really get involved and advocate and fight for it. As some of you, I hope some of you will run for office. I hope some of you will get very much involved outside of your practice of medicine, whether it be in healthcare policy or advising people that are running for office, because I do think that we need more physicians to bring in their perspective and understand what's good and bad about our healthcare system. So with that, I really do thank you for taking time to allow me to share this talk with you today.
Thank you so much, Dr. Song. There's two questions that were asked by the audience, and I'll put them here. I don't know if you can see them.
Okay.
The first question is, how do we engage more physicians in this discussion around patients' access to healthcare?
Well, again, that's what I think we really need to do a better job of making sure that we don't falsely equate coverage with access to care. Because if you've got one of these really bronze, crappy-ass plans that have a $6,800 or more deductible, annual deductible, and maybe a $250 copay, most people don't have that kind of money sitting around. And what I found was, if you have that, somebody who feels a lump in their breast or a lump in their neck, because the first $6,800 of all of their workup has to come out of their own pocket, is going to delay seeking care. So the first thing I think we have to do is make sure that we do not automatically allow people to say coverage equals care or access to care. So that's the first thing that I think we all need to really just educate people on.
The next question: how do we communicate better about what the trade-offs actually are? It's easy for opponents of universal health care to quote these eye-popping numbers and scare the public. So what are good ways to change the conversation on the true comparisons?
So I will say I'm not sure how these would scare the public. All you have to do is be practicing in this healthcare system long enough to see how scary it is for your patients. Again, access to care, narrow networks, all of the things that I showed you, losing your employer-sponsored healthcare during the pandemic, the rationing of care, those are pretty scary things that exist right now without a universal healthcare system. So I'm not sure what trade-offs people are really questioning. I would ask the person who asked this question, what do they think is so great about our healthcare system now that we would lose by giving everyone an enhanced coverage? Now, from a physician standpoint, I will say this. I didn't put it in my talk, but if you look at the American Medical Association and several studies, and I can send them to the group, when they looked at how much the average doctor in the United States has to spend on filling out paperwork or filing for pre-authorization or denial of care, it's over 20 hours a week that you have to spend time doing that above and beyond just your charting of paperwork. And then the average doctor back about 10 years ago was spending $89,000 per doctor in practice to hire somebody to basically handle the billing and handle pre-authorization and all of those things. So one of the concerns I've heard is, well, a Medicare for All plan would reduce my reimbursement. And I would say that you would actually, it would free you up because you would have more time to spend with patients. You could see more patients in a week than you currently have. You would reduce your administrative costs because you wouldn't have to hire somebody to handle all of these billing intricacies. You wouldn't have to spend all this time on the phone fighting for copays and denials and pre-authorization. And then finally, because the biggest cost associated with malpractice is not the negligence, but it's the continual payment of care to take care of that person for the rest of their lives. If there's a Medicare for all system, their healthcare coverage is covered forever. So that's why malpractice rates are dramatically lower in countries that have a universal government healthcare system. So I would say that unless you are one of the really big specialists like a dermatologist or plastic surgeon, and some of my friends are, that already cash pay, they're not going to see any trade-offs. But some of the other specialties, you might get slightly less reimbursement. But I think once you look at the total cost of running your own practice, you will actually have a better situation. Also, I don't know what the degree of how many of you who are practicing are, but for those of you who are looking to start your own shingle, or if you talk to most of the doctors that are like my generation, it's hard for most standalone practices to practice anymore because either the hospitals have become so powerful or the insurance companies have. So many times they're selling their practices to the most powerful hospitals in the agency and going to a contract, SVU, relative. They keep track of how many patients you see in a certain period of time. And it really is an awful way to practice medicine. If you did away with all of that, you would basically take away the power from the hospital association as well as the insurance industry, and you could go back to hanging out your own shingle and reducing your administrative costs and burden and have a much greater practice and be able to practice medicine the way you really wanted to.
Gotcha. I think those are the only questions we have.
Well, again, I want to thank you all for tuning in. I would ask you again to not just take my word for it, but to really devour the literature and see what is really the metrics are. But all of the things that you've heard up to now, and I'm saying from both sides of the aisle, not just from the right, but also from the left, a lot of the comments were simply not true. So what I'll do, with your permission, is I will send this PowerPoint presentation to the organizers, and anybody who wants it is happy to feel free to download it and use it as you want. And if you find anything in there that you don't think is true, please reach out to me. I'm always trying to learn as well, and I would love to engage any of you that has any questions.
There's one last question, and I don't want them to miss out. Here's the question.
Yeah, so that is the problem. Like I have some friends who are freelance radiologists as well, and if they're not in a network, they basically are being salaried employees by somebody who owns an imaging center. But the advantages again would be for a lot of these folks who are solo practitioners is that you would directly get reimbursed in a Medicare for all system. You would not have to negotiate, unlike Blue Cross that's going to shop your rates against another radiologist, and sometimes they don't even come to you because they've signed a contract with the largest radiology group. You really have the ability, you will automatically be enrolled in Medicare for all plan. And one last thing I'll say is if you look at the average salaries, go to the website and Google average salaries in Canada of everything from internal medicine to ophthalmology. I think you will be very surprised at how well the doctors are reimbursed and paid in that country. And remember, their administrative costs are a fraction of what we pay. Their malpractice costs are roughly 20% of what we pay in the United States as well. So, again, from a physician standpoint, maybe people who practiced for 25 years when it was golden and they could get these top paying contracts that paid twice of Medicare and they could practice like they were gods. Those days are gone. And right now, what you'll find is you will spend more time fighting with insurance companies. And if you're not fighting insurance companies, many times you'll fight with big hospitals that some case administrator that will tell you how you didn't see bill enough for that month. So it's really taken away the joy of practicing medicine, which I think would a large part be restored with a Medicare for all system.
Awesome. I think that's it. Thank you so much, doctors.
Well, again, thanks so much for having me, and really good luck to you all. I hope some of you will roll up your sleeves and run and get much more involved in the process, because I think we do need more physicians in elected office.
Awesome.
All
Thank
right.
you. Take care. Good night, everyone.
Thank you. Thanks. Bye-bye.